Bismillahirrahmanirrahim. Quote of the day is La yukallifullahu nafsan illa wus'aha. Allah does not burden a soul beyond that it can bear. This is the quote from Quran. My name is Dr. Aamna Khalid. I'm PGR Community Medicine and I will be presenting the topic of human papilloma virus under the kind supervision of Professor Dr. Saira Afzal, who is Dean Institute of Public Health. The learning objective of today's presentation will be the introduction to HPV, its types, transmission, associated risk factors, epidemiology, clinical manifestation, prevention and screening, diagnosis, treatment and management, public health implications, and then we will do the practice of MCQs. So HPV is the most common sexually transmitted viral infection worldwide. It has more than 200 genotypes. Major cause of cervical cancer and other anogenital and oropharyngeal cancer is HPV, and persistent infection with high-risk types will lead to malignancy and its significant public health burden despite availability of the effective vaccines. So the transmission of HPV is primarily through the direct contact with infected skin or mucosa. The first one is the sexual transmission. Either primary route, this is transmitted through the sexual contact, including the vaginal, anal, and oral sex. And either it can be skin to skin contact, means through the intimate genital contact. Then it can also be transmitted via non-sexual routes like vertical transmission, although it's rare, but it can lead to conditions like recurrent respiratory papillomatosis in the infant. Formal transmission can be there. It can spread through the contaminated objects like shared towels or medical instruments. It's more likely associated with the low risk HPV types. Then auto inoculation can also be there. HPV can spread within the same individual, such as transferring the virus from one part of the body to another, from genital to oral regions through touch. So the incubation period of HPV infections ranges from 3 weeks to 8 months, and its communicability is high, and transmission is possible even without visible lesions, and risk increases with the multiple sexual partners. So now we will discuss the epidemiological determinants covering agent factors, host factors, and environmental factors. The agent factors are that it's the human papilloma virus belonging from the family Papillomaviridae. The virus type is non-enveloped double-stranded DNA, and its structural stability actually allows survival in the environment. Tropism involves the squamous epithelial cells of the skin and mucosa. It infects basal cell layers through microabrasions and contribute to the efficient transmission. Host factors involve the low immunity of the individual, like having HIV infection or malnutrition, early age of sex, multiple sexual partners, poor genital hygiene, smoking, and alcohol use. Environmental factors are the low awareness and health literacy. It limits preventive health seeking behavior, or the limited access to screening and vaccination, especially in the underdeveloped or rural areas. Cultural barriers to gynecological care, it will delay the diagnosis and treatment, and weak health system can cause poor follow-up and surveillance. So HPV can be classified into the two main categories based on their association with cancers. The first category is low risk HPV. These actually cause warts. They are typically benign, and mainly HPV type 6 and 11 are the causative agents in low risk HPV. They are responsible for about 90% of the genital warts cases. In high-risk HPV, these now leads to cancers, including cervical, anal, and oropharyngeal cancers. HPV 16 and 18 are the most common ones, causing around 70% of the cancers. And other also includes 31, 33, 45, and 52. So the clinical features have a broad range. It can be asymptomatic infection, which is the most common presentation, and a majority of the virus clears spontaneously in this case. There can be benign lesions with the presentation of genital warts called condyloma acuminata, and these warts actually causes psychological and social distress to the patient. There can be pre-malignant lesions, the cervical intraepithelial neoplasia, CIN1, 2, and 3, and these are detectable through screening. Then the last resort is malignancies, cervical, anal, vulvar, vaginal, penile, oropharyngeal cancers, and these are associated with the persistent high-risk HPV. So first we will discuss the symptoms of low risk HPV types, as we said that they cause warts. So in case of genital warts, the condyloma acuminata, soft fleshy growths are there in the genital or anal region. They may be flat, raised, or cauliflower-like and caused by HPV 6 and 11. Often these are painless but can cause itching, discomfort, or bleeding. Then some common warts, these are rough, raised growths on the hands, fingers, or knees, and again by the low risk HPV. Plantar warts are hard, painful growths on the soles of the feet, and these are caused by type 1 and 2. Then flat warts, these are smooth, flat topped lesions on the face, neck, or hands. These are the pictorial manifestation. You can see where that we studied about the common wart, then the flat wart, plantar wart, and genital wart, and you can see their pictures. Okay, respiratory symptoms, as we said that in case of vertical transmission, the respiratory symptoms appear in the infants, and they suffer from recurrent respiratory papillomatosis. These are characterized by the benign growths in the airways, leading to hoarseness, chronic cough, difficulty in breathing, or stridor. And again, it's more common in young children because of the vertical transmission. So this is the pathogenesis that you can see the normal cervical cross section, and when HPV infects and invades the basal epithelium, then it starts progressing into the CIN1, then 2, then 3, and then a fully developed cervical cancer, and it may be an invasive cancer. And you can see that persistent infection ranging from 1 to 10 years is required for the transmission of this um, um, from normal to cancerous lesions. So for the diagnosis, we can have a clinical diagnosis by the visual inspection of the warts, and usually is sufficient for the diagnosis. And then we have a screening test including pap smear that detects the cellular abnormalities, and visual inspection with acetic acid VIA that's useful in the low resource settings. And then we can go for the molecular test including HPV DNA testing, which identifies the presence of high risk virus, and then genotyping that also guides about the risk stratification. For management, as we divided into the four categories, the first category was asymptomatic infection, so no treatment is required for the asymptomatic one. We just have to focus on the counseling and follow up, and over treatment should be avoided in this case. Then the second category was warts. So for warts, cryotherapy, podophyllin, these can remove lesions, but not the virus. In case of precancerous lesions, we can again go for the cryotherapy or LEAP. LEAP is loop electrosurgical excision procedure, and it prevents progression to cancer. And if a fully developed cancer is there, we have the options of surgery, radiotherapy, chemotherapy, and depends on the stage and resources. So now we move to the prevention, and the first level of prevention is the primary one, which targets for preventing the occurrence of HPV infection. We have the option of vaccination. We will discuss it in detail. Then safe sexual practices should be adopted using condoms, though not 100% effective, but it lowers the likelihood of infection. Then limiting sexual partners, avoiding smoking, because smoking weakens the immune system. Gender empowerment, it improves the access to care, and a delay in the age of sex. Then HPV vaccine, sorry, okay, sorry. The first HPV vaccine became available in 2006, and currently there are 6 licensed HPV vaccines. Three are bivalent, and two are quadrivalent, and one is nonavalent. The bivalent vaccine is the Cervarix and Secolin. Secolin, as you know, was the vaccine used in the recent awareness campaign in our country. We will discuss it later. Quadrivalent vaccines, okay, and bivalent vaccine is actually against the two types of HPV. These are 16 and 18 mainly. Then quadrivalent vaccine, like Gardasil, these target type 6, 11, 16, and 18. And nonavalent vaccine like Gardasil 9, these protect against 9 types: 6, 11, 16, 18, 31, 33, 45, 52, and 58. So these are the recommendations for HPV vaccination. The schedule is for 9 to 14 years. We have to give 2 doses, and if the person is 15 or above, then we have to give 3 doses. Intramuscular, it's given in the deltoid muscle. 90% efficacy is achieved against vaccine type infections, and it's proven in multiple trials. And it has an excellent safety profile. Only minor local reactions are common. And then HPV vaccines are not recommended for use in the pregnant women, and women who have received HPV vaccine should continue routine cervical cancer screening. So this is not the replacement of screening, that should be continued. Okay, secondary prevention involves the early detection and intervention to prevent the progression of HPV. We have to detect the genital warts by using the pap smear or HPV testing. Genital warts testing and findings. We use 5% acetic acid to identify both the warts and the squamous intraepithelial neoplasia, the CIN, squamous cervical. With It has a limited success by causing abnormal tissue to appear white. Then the key methods, as we said, are pap smear and HPV testing, and these are the guidelines of doing the pap smear. According to the American Cancer Society, the women aged between 21 to 29, their pap test should be done every 3 years. Then women aged 30 to 65, the co-testing with PAP plus HPV test, the DNA testing, etc., should be done every 5 years. And this is the preferred one, or PAP alone every 3 years. Then screening is independent of the HPV vaccination status. So HPV test involve the DNA-based test and the RNA-based test. DNA-based tests detect the high-risk HPV types, and FDA approved for identifying the 16, 18, and some other types. And RNA-based tests detect active infections with high specificity. The benefit of co-testing is that it reduces the false negatives and increases the detection rates. So men should also be tested for the HPV, and although currently we have limited routine tests available for them, but they should be tested. The detection of high risk types on the genital skin, urethra, and semen. This should be done. All right. Then we move to the tertiary prevention, and that's managing and mitigating the impact of HPV-related disease. We have to do the treatment of invasive cancer to reduce the mortality and the quality of life of the patient. We have to do the rehabilitation and palliative care. So again, we have to treat the genital warts. This was discussed in the previous slide. And we also have to monitor for the recurrence. For individuals who have been treated with the precancerous changes or the HPV-related cancers, regular follow-up and monitoring are important to detect any recurrence or new developments early. So this is again the depiction of the primary, secondary, and the tertiary prevention. Primary prevention, mainly through the vaccination in targets the girls ranging from 9 to 14 years, and then secondary prevention, we start screening the women. So 30 years above are the main targets, and again tertiary prevention. After the development of the cancer, we target the women about 30. Okay, now we move to the burden of the disease, and you can see that this is the data taken from 2022, and the rate of new cervical cancer cases is shown. Although Pakistan is in the lighter shade, and in 2022, per 1 lakh women, 5.4 women were affected. These are the number of new cases and deaths from cervical cancer worldwide, and you can see that till to 2021, new cases have been reported, and there was a significant rise in the cases and also in the deaths. So this is the share of invasive cervical cancers caused by each HPV type, and you can see that HPV type 16 is the most common. It causes around 61% of 61.7% of the invasive cervical cancers are attributed to HPV 16. Okay, this is the share of cancers attributed to the 9 HPV types worldwide. The data is taken from 2019, and you can see that cervical cancer is on the fifth number, and 89.3% of the cervical cancers are due to HPV, and the anal cancers are the highest among the cancers caused by HPV. Okay, this is the share of adolescent girls vaccinated against HPV. The data is from 2024, and unfortunately, the data from Pakistan was not reported. And you can see that the darkest shade shows that they have added their the HPV vaccine in their national programs. This is the data from Pakistan that um, uh, every year, around 5,000 women are diagnosed with cervical cancer, and 3,197 die from the disease. About 0.5% of the women in the general population are estimated to harbor the cervical HPV 16 or 18 infection at a given time, and 88.1% of the invasive cervical cancers are attributed to HPV 16 or 18. This is again the picture of the same thing. Okay, this was the campaign that occurred in our country, Pakistan, from September 15 to 27, and then it was further extended for 3 days. 9 to 14 years girls were targeted, and a free vaccination was given to them. Okay, this is taken from the website of Gavi, which was the main sponsor of this vaccine. That despite a wave of misinformation, because the misinformation was that the target has not been achieved, so they claimed that after the 3 days extension to the campaign, as I said, overall coverage among the eligible girls had reached 71%, and 9.2 million girls were vaccinated. Okay. This is the global strategy to accelerate the elimination of cervical cancer as a public health problem. And the 2030 target for the elimination of cervical cancer by WHO. 90% of the girls fully vaccinated with HPV vaccine by 15 years of age till 2030. 70% of women screened using a high performance test by 35 years of age, and again by 45 years of age. And 90% of women identified with a cervical disease are treated. 90% of women with precancers are treated, and 90% of women with invasive cancer will be managed. This is their target for 2030. So to achieve the 90%, sorry, to achieve the 90% coverage of HPV vaccination, the strategic actions designed by WHO are: secure sufficient and affordable HPV vaccines with a partnership between the private sectors to overcome the vaccine supply constraints, and with vaccine with the more affordable prices, and increase the quality and coverage of the vaccination by multi-sectoral delivery platforms and monitoring systems, and improve communication and social mobilization by nationwide evidence-based communication. Social, cultural, societal, and other barriers should be understood and then managed accordingly, and innovate to improve efficiency of vaccine delivery by national guidelines, policies, and strategies. Okay, this meta-analysis was published in 2024 to see the clinical effectiveness of one dose vaccination with an HPV vaccine, and they have shown in their results that a single dose HPV vaccine may offer effectiveness on par with 2 or 3 dose schedules. So conclusions drawn from its capacity to confer immunogenic protection for at least 8 years of follow-up, coupled with its ability to mitigate infections and precancerous recurrence. Further trials are also going on for the one-dose vaccination. So again, AI-assisted cervical cytology precancerous screening for high-risk population in resource-limited regions using a compact microscope and they concluded that the system achieves area under the ROC curve values of 0.87 and 0.89 for detecting squamous intraepithelial lesions on 364 slides. Um, and these findings demonstrate the feasibility of our AI-assisted approach for effective detection of high-risk cervical precancerous lesions among women in resource-limited regions. So the accuracy and acceptability of self-sampling HPV testing in cervical cancer screening, a population-based study in rural Yunnan, a study from China, published in 2025. They say that WHO recommends that HPV self-sampling should be made available as an additional approach in cervical cancer screening services for women aged 30 to 60 years, and self-sampling can help reach the global target of 70% coverage of screening by 2030. So population-based studies have indicated that self-sampling HPV testing showed similar accuracy with the provider sampling HPV testing. Furthermore, women may feel more comfortable taking their own samples rather than going to see a health worker for cervical cancer screening. So these are the recommendations and future directions that awareness campaigns should be done, especially before the campaigns of starting the vaccinations, and integration of the vaccine into the national immunization program and screening program should be made more effective. So now we come to the practice of MCQ. So question number 1 is, a 25-year-old woman visits her physician for a routine checkup. She is sexually active but has never undergone a pap smear test. What would be the recommended course of action? Option A, administer immediate HPV DNA testing. Option B, perform a pap smear and recommend HPV vaccination if unvaccinated. Option C, wait until symptoms develop or prescribe antibiotics or start a single dose antiviral regime.
B.
Yes, option B is the right answer. Sorry. Question number 2. A healthcare worker is running an awareness campaign in a low-income community with limited access to vaccines. What key message should be emphasized? Option A, HPV is incurable and inevitable. Option B, vaccination is ineffective after sexual activity begins. Option C, vaccination and screening can significantly reduce HPV-related cancer risk. Option D, HPV only affects women. And option E, vaccination is not necessary if one has good hygiene.
C.
C.
Yes, C is the right answer. Question number 3. An immunocompromised individual is diagnosed with persistent HPV infection. What is their risk compared to the general population? Option A, low risk of HPV associated cancers, or equal chance of HPV clearance, or a high risk of progression to cancer due to impaired immune response, or a no risk of HPV related complications, are more prone to develop other sexually transmitted diseases.
C.
Yes, C is the right answer. Question number 4. A 19 years old patient asks about the benefits of HPV vaccination after becoming sexually active. What is the correct advice? Option A, vaccination is ineffective after sexual activity begins. Uh, uh, Option B, vaccination can still provide protection against types of HPV the patient has not been exposed to. Option C, all right. Option C, vaccination cures existing HPV infections, or vaccination is only for children, or vaccination can cure cancer related to HPV.
B.
Yes, B is the right answer. Question number 5. A country is planning to introduce an HPV vaccination program. What is the ideal target population for this program? Option A, adults aged 25 to 35 years. Option B, include it in EPI. Option C, adolescents aged 9 to 14 years before becoming sexually active, or elderly individuals or infants under 1 year.
C.
C.
Yes, option C is
C.
the right answer. Yes, option C. Okay. Question number 6. A woman in her late 40s is concerned about her risk for cervical cancer. She reports regular pap smears but has not received the HPV vaccine. What should her doctor recommend her? Option A, continue regular pap smears as they are effective for monitoring cervical health. Option B, HPV vaccination should be administered immediately. Option C, discontinue pap smears too as she is not vaccinated. Option D, HPV vaccination is not effective at her age. Option E, vaccination is ineffective after sexual activity begins.
B.
A.
B.
Yes, option A, pap smear should be continued. Question number 7. A country is launching a national HPV vaccination program. The Ministry of Health plans to vaccinate individuals between the age 20 to 30. What would be an important consideration? Option A, vaccination at this age group may have limited efficacy as many may already be exposed to HPV. Option B, this is the ideal age group of HPV vaccination. Option C, the program should target males only. Option D, booster doses will not be needed in this group. Option E, start this program in more younger age.
A.
E.
So,
A.
yes, option A is the right answer. Question number 8. A 35-year-old woman tests positive for high-risk HPV during routine screening. What is the next step in management? Option number A, immediate surgery. Option B, colposcopy and biopsy to evaluate for precancerous or the cancerous lesions. Or start HPV antiviral therapy, or reassure and repeat the test in 5 years, or consult her about the surgery.
B.
Yes, B is the right answer. Question number 9. A 13-year-old boy is brought to the clinic by his parents for immunization. They express concern that her HPV vaccination is only for girls. How should the physician address this? Option A, tell them HPV only affects women, or explain that boys at young age are not prone to HPV, or emphasize that HPV vaccination is recommended for both boys and girls to prevent cancers and genital warts, or postpone vaccination until adulthood, or recommend only tetanus vaccination.
C.
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 Yes, option C is the right answer, recommended in both of them. Question number 10. A mother infected with HPV delivered a baby. Which of the following HPV related condition can occur in the offspring? Option A, genital warts, or respiratory papillomatosis, or cervical cancer, or penile cancer, or skin cancer. Okay, it's option
C.
B. Respiratory papillomatosis occurs in the infants. This is the key to all of the questions. This is a YouTube channel of Institute of Public Health where this presentation will be uploaded. Thank you so much.
Dr. Amna, it was a wonderful